You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 27th, 2019. First, a few announcements. This Week in Cardiology is taking a week off, as next week I'm at the Venice Arrhythmia Symposium, and then right afterwards in Rzeszów, Poland for the PQRS-T conference. I'll return in 2 weeks. Last week I received a very nice email from a listener, and I'm grateful for these kind words. There are many podcasts out there, and so if you like this one, please consider subscribing and writing a review on whichever app you use. That helps other people find us. Also, the web page for this podcast comes up on the heart.org Medscape Cardiology homepage. There are links to the stories that I cover in a comment section, and if you disagree with me or have another point to make, please consider leaving a comment. The first topic today diverges a bit from pure cardiology and deals with screening for disease. September, after all, is AFib Awareness Month. And of course, the excitement for doing coronary artery calcium scans, however misplaced, shows no upper bound. Medscape Oncology astutely covered one of New England Journal's most important perspective pieces of the year. It tells the story of Mr. B, a 66-year-old, highly intelligent and formerly well man who, despite being careful and skeptical, fell prey to iatrogenesis from the medical field. This led to regret, and regret is one of the main forces that drives my medical conservatism. Now, New England Journal doesn't mention one of my favorite medical critics, but this case made me think of Ivan Illich. Here, the iatrogenesis that harmed Mr. B wasn't just a pure clinical and direct harm, but what Illich called social and cultural iatrogenesis. Social iatrogenesis refers to the medicalization of life or the sickening of society. Cultural iatrogenesis refers to the destruction of traditional ways of dealing with and making sense of pain, sickness, and death. Illich likened the medicalized society as morbid, and through the medicalization of death, healthcare has become a monolithic world religion, he wrote. One of the authors of this New England column, Robert Aronowitz, has previously written on the converged experience of risk and disease. That is, in days past, people presented to doctors with manifest disease, symptoms, for instance. But now, in the era of PSA tests and mammography and prediabetes and CAC scores and Apple Watches, people who are well, or as I call them, people without complaints, can experience having the risk of a disease as similar to having a disease. In short, Mr. B had a positive PSA way back in 2006. It was the era before RCTs that showed no mortality benefit from PSA screening and no advantage to surgery over watchful waiting. After careful thought and an experience knowing a person who had metastatic cancer, and Mr. B's wife's encouragements to do everything possible, he had robotic surgery. He then suffered incontinence and impotence. He dealt with these as expected side effects, but then his suffering worsened when he learned of the RCTs. He, quote, struggled to understand how the data he'd reviewed just a few years earlier had made him confident about surgical intervention. Now, the transcendent value of this column comes when authors Aronowitz and Jeremy Green expand on the concept of a social medicine perspective, in which society or society's culture shapes the notion of health, disease, and recovery. This, they write, includes the way medical knowledge is used. In this case, a PSA transforms someone into a cancer patient. In cardiology, a CAC scan can transform a person into a patient with heart disease. An Apple Watch can transform a person with asymptomatic PVCs into a heart patient. What to do with these new labels is a matter of uncertainty and is due to inadequate medical knowledge. And the authors argue that medical progress, or simply gaining more information about a disease, might not ever resolve the problem of this instability of medical knowledge. This is, of course, because categories of diseases like diabetes, hypertension are not stable. They are moving targets because our actions interact with them and change them. They call this feedback a looping effect. Our feedback patterns over diagnosis and intervention in health behaviors influence the natural history and prognosis of disease. Knowledge produced by us, our investigations, changes the way we diagnose and treat people, which in turn transforms the epidemiology and profile of the disease itself. As screening increases the number of people with the disease, society sees more people living with the condition. Everyone knows a cancer survivor now, and more people know an AFib patient. That these patients are alive and well gives a false sense of causality. People think it must be because of all those early screening programs. Now, neither Mr. B nor his doctors knew they were creating conditions that made screening seem to work. Then, of course, there's the problem of language. Calling a condition cancer or heart disease changes people's belief and actions. It generates fear and the possibility of regret. Remember, as healthism increasingly pervades our culture, the less autonomous power people have to cope. People feel pressure to choose more aggressive treatment. As Robin Hanson wrote in The Elephant in the Brain, going against the caring signals of society and not getting your PSA or not getting a colonoscopy or carotid screening test breaks a norm. Mr. B wished he'd been aware that he and his doctors were partaking in a powerful self-reinforcing social process. Cultural iatrogenesis is harmful exactly because it allowed Mr. B's doctor to do the initial PSA without much thought. And compared against the coming explosion of digital health and its gadgets that will medicalize our lives, PSA screening looks pedestrian. Aronowitz and Green wisely call for clinicians to strive to reduce the evidence-free spread of purportedly risk-reducing interventions, not just on clinical grounds, but also on societal grounds. And I commend them and the New England Journal for publishing this piece. Just doing a PSA, recommending a Cardia app or an Apple Watch, or having a CAC score can have effects well beyond the test results. Indeed, being a medical conservative has never been more important. Second topic today is another short note on the SGLT2 inhibitors. At the Heart Failure Society Association meeting in Philadelphia, a group from New York presented a small study looking at the effects on SGLT2 inhibitors in patients with heart failure with preserved ejection fraction and diabetes. Recall that the recent positive news on dapagliflozin from the DAPA heart failure trial was in patients with heart failure with reduced ejection fraction. The New York group presented data on 141 patients with diabetes and heart failure with preserved ejection fraction who had an echo before initiation of the SGLT2 inhibitor drug and then 1 year after the drug. The results surprised me. Instead of showing favorable effects on diastolic function, the echo after the SGLT2 inhibitor found modest but statistically significantly average increases in LV mass, LV end systolic and diastolic volumes, LA volume, and other markers associated with diastolic function. Left ventricular ejection fraction on average did not change. Here's why this not yet published abstract is worth a note. We don't know the mechanism of cardiovascular benefit of these drugs. These observations do not suggest it's via LV remodeling, at least in patients with preserved EF. But I still think we are on a leading edge of understanding these drugs, and as Steve Stiles noted in his news story, multiple trials are ongoing. Third topic today is cardiac device infections. A nice report from Mayo researchers, along with colleagues from China, assessed temporal trends in cardiac device infections over the past 3 decades. The data came from the Rochester Epidemiology Project, and this is a medical record system involving all individuals residing in Olmsted County, Minnesota. This is a neat system as it provides access to the details of healthcare of local residents regardless of their health provider. Over the period between 1988 and 2015, about 2,100 patients had an implanted device, of which there were 59 infections. So that's about a 2.7% incidence of infections. And the four key findings of this paper, which was published in JACC Electrophysiology, were that the incidence of device infection is indeed increasing. About half the infections occur in de novo or new implants, and the other half occur with gen changes or revisions. They also found that the cumulative probability of an infection is higher in the ICD and CRT groups. And after the third cardiac device procedure, the risk is especially high at 5%. Obviously, this is a small retrospective study that does not tell us why infection rates are on the rise. But it makes the podcast because I feel the risks of cardiac device infections are under-recognized. Yes, cardiac devices surely help people, but complications occur, and complications act as a drag on the net benefit of these devices. While all infections are bad, it's especially terrible after a generator change. In patients who have an infection after a new implant, you can take the system out and remove leads without a lead extraction struggle. But it's different for gen changes. If a person with a 10 to 20-year-old lead gets an infection, they then have to face the risks of a complicated lead extraction procedure. So will a patient presenting for his or her third ICD gen change get the same benefit they did from the first implant? Competing risks of mortality often overshadow the risks of arrhythmic death. Thus, in non-dependent ICD and CRT patients, I often have a frank conversation about not doing the gen change. It sometimes catches people by surprise, but when you cite these high rates of infections, a conservative approach can make sense for some patients. Next topic is equal pay and opportunity in cardiology. Earlier this month, the ACC published a policy statement that promoted equal pay and opportunity in cardiology. Dr. Pamela Douglas chaired the writing committee, and the document outlined 17 principles for achieving equity. As background, a 2016 study found a $30,000 plus annual salary gap between female and male cardiologists even after adjustment. This amounts to more than $1 million difference over the course of a career. Now, time doesn't allow me to go over the 17 principles, but I'm really glad the college put this down in writing. My experience in cardiology has been blessed with female colleagues. First, I had Suzanne Noble as a mentor at Indiana. She demanded excellence at the bedside. There were no excuses. And then we were moonlighting at St. Vincent's during fellowship, and I got to learn from the great Janet Rippey, another master clinician. My first private practice group that I joined here in Louisville had Dr. Janet Smith as the managing partner, and she was one of the hardest working doctors I have ever met, period. And now I have 2 female interventionists and 3 general cardiology female colleagues. Here at Baptist Health Louisville, women in cardiology is a normal thing. Now, the reason this topic makes the podcast is simple. Equal pay and opportunity is the right thing to do. Full stop. Last topic today is monotherapy after PCI. Now, another large RCT informs the choice of antiplatelet therapy after a PCI. The Twilight trial presented at TCT and published in New England Journal compared ticagrelor alone versus ticagrelor plus aspirin after 3 months of standard dual antiplatelet therapy. The primary endpoint of Twilight was bleeding. MACE was a secondary endpoint. Patients had either ACS or chronic stable coronary disease. The doctor had to intend to use ticagrelor and aspirin dual antiplatelet therapy, and these patients had to have at least one clinical feature and one angiographic feature associated with a high risk of ischemic or bleeding events. So these were high-risk patients. Enrollment occurred at the time of the PCI, but randomization did not occur until 3 months, so about 2,000 patients were excluded after enrollment. That left about 3,500 patients in the 2 groups. Unlike the 2-year Global Leaders trial, which found that ticagrelor plus aspirin for 1 month, followed by ticagrelor alone for 23 months, was not superior to 12 months of standard dual antiplatelet therapy, followed by 12 months of aspirin. Twilight was a 12-month trial. And Dropping aspirin and using ticagrelor alone clearly looked better in Twilight. Bleeding occurred in 4% of the monotherapy group and 7.1% of the ticagrelor plus aspirin arm. Major adverse cardiac events, or MACE, occurred in 3.9% of the groups. Notable aspects of this trial relevant to its external validity are that it applies only to patients who make it to 3 months with good adherence and no major events. That means the decision on dropping aspirin shouldn't be made at the time of the intervention. The authors also made clear that these were higher risk patients, so whether it applies to lower risk patients is not clear. The MACE endpoint wasn't underpowered to detect differences. However, stroke rates were double in the ticagrelor alone group, but the small absolute numbers preclude making definite inferences. Now, looming over the results here, I can't help but think of the ISAR React 5 study published a month ago that showed prasugrel was far superior to ticagrelor in reducing MACE in patients with ACS. I'll close with a non-interventionalist comment about PCI, especially when it's done in patients with stable coronary disease. This immense amount of science regarding anti-thrombotic therapy after PCI and stent underscores the fact that this procedure is not a risk-free fix. Yes, it nicely improves the physics of blood flow through a stenosis, but the cost is a metal cage in the coronary, dependence on clot-blocking drugs, and the risk of neoatherosclerosis at the stent site in the long term. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And I'll see you in 2 weeks. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.